Good afternoon and welcome. On behalf of the Association for Molecular Pathology and the Pan American Society for Clinical Virology, my name is Kevin Albee, and I would like to welcome you to today's jointly sponsored webinar entitled Zika virus, Diagnostic Testing and Frontline Management. This webinar will feature two presentations with questions being answered after the conclusion of the second presentation. You can utilize the control panel at any time to submit questions for the end of our program. Our first speaker today is Dr. Cecilia Perret from the Pontifical Catholic University of Chile. She is a pediatrician and infectious disease consultant who has focused on tropical medicine for the last 20 years. She will share with us her experiences and talk to us about Zika virus. What do we know so far? Take it away, Dr. Perret.
Thank you very much. Good afternoon, everybody. Thanks for the invitation to participate in this conference, and I will present about what do we know so far about epidemiology and also complications, new forms of transmission and prevention of this new infection in the Americas. Sorry, I can't advance my presentation. There we are. Well, Zika virus is an arbovirus that is transmitted by the Aedes, mainly Aegypti, but also Albopictus. It belongs to the same family, which is Flaviviridae, same family of dengue and West Nile viruses, and also yellow fever. The mosquito is spread in several countries in the world, but mainly in Latin America and the Caribbean. The virus was first discovered in 1947 while researchers were doing an investigation of febrile monkeys in the Zika Forest Research Station, and what they thought they will isolate a yellow fever virus, it was a new virus that meant to be Zika virus. From that discovery, many years ago, few human cases appeared, 1969, until 2007, when the first outbreak occurs in the Yap Island in the Micronesia. Between the isolation of the virus in Africa and this big outbreak, only few human cases were reported. So mainly was an unknown disease until 2007. At that time, on Yap Island, it's thought that 73% of the population was infected, with 185 symptomatic people. No hospitalization and no complications were reported during that outbreak. 2013 and 2014 was the time that the new outbreak appears in French Polynesia. About 32,000 cases were notified during that outbreak, and more or less 66% of the population is thought that was affected. Again, no hospitalization, no complication, no mortality was reported during that outbreak, but at that time, the authorities of the island, they alert that they have an increase of Guillain-Barré syndrome cases during the outbreak. We can see here in this map the number of countries from 2013 to today that are affected or have been affected with the virus. And here is what's going on in the Americas after the introduction of the virus 2014, first on Easter Island, and later on the spread to the rest of the continent. The second country on the Americas that was affected, it was Brazil, that besides the cases start to be reported the beginning 2015, now we know that the virus was probably introduced at the beginning of 2014 or even at the end of 2013. The second country affected was Colombia, and all of them, they have a going on outbreak at the minute. More than 600,000 cases has been reported up to today in Latin America and the Caribbean, and the country with the highest number of cases is Brazil. Here we can see how is the outbreak going on the continent, and we have the peak of the infection around February of this year. Despite, we can see here the numbers, the weekly numbers are starting to decrease. We still have a number of countries where the number of cases are increasing. But not all is Zika virus. In the Americas, other viruses transmitted by the Aedes are still present. And we can see here as an example, in Honduras, the beginning of this year, the three viruses, Zika, dengue, and chikungunya, are circulating simultaneously. So this is very important because the consequences and complications of these other two viruses are for far more important than Zika virus, so we have to keep them on mind. What happened on Easter Island 2014? We knew that we had infection of Zika virus more or less at the end of February of that year, and with the epidemiological studies, we realized that the virus was introduced at the beginning of January. And the studies of the outbreak there conclude that about 170 people were symptomatic. We don't know exactly the amount of people that was really infected, and out of those cases, 51 of them were confirmed by PCR. The genetic analysis of the virus was done, and we can see here, this is the sequence of the virus from the French Polynesia, and these are the Chilean samples of virus, and we can see they have 100% identity. So the conclusion is that the virus was introduced from the French Polynesia to Easter Island at the beginning of 2014. The mosquito Aedes aegypti is present on the island from the year 2000, and we had an outbreak before of dengue, dengue 1, 2002. What are the clinical features of this virus? First of all, we see here that the incubation period is between 3 to 12 days, and 80% of the infected people are going to be asymptomatic. From those that had symptoms, they will last for 4 to 7 days. The majority of them will have a very light disease, and the main symptom is rash. And 94% of the people will present with rash. Most of the time it will be an itchy rash, maculopapular. But another clinical feature that is very specific of this virus is the conjunctivitis, red eyes without secretion, and also the presence of lymphadenopathies behind the ears or occipital. In our lab, we have diagnosed 12 cases of Zika virus, 7 females and 5 males, where they have been exposure in Brazil, Colombia, and Venezuela, and 1 case from Haiti. The average age was 31 years old, and we had a case of a pregnant woman and 1 case of sexual transmission. So let's see in details what's with the case of the pregnant woman and the case of sexual transmission. This is a pregnant woman who traveled to Colombia while she was in the 28 weeks of gestation. She traveled to San Andres, the island of San Andres, at the end of November 2015. And 1 day after she returned from her trip, she presented with rash, itchy rash, conjunctivitis, and arthritis on her hands that last for 5 days. At that time, Zika virus was an unknown disease and nobody suspected it, and she was diagnosed as allergy. So when we had the opportunity to study her, that was at the delivery, she was Zika IgG positive. We had ruled out before dengue and chikungunya. So she delivered a healthy boy with a normal cerebral ultrasound and a normal neurological examination. And he is at the minute IgG positive, probably maternal transmitted antibodies, and he was PCR negative for Zika virus in his blood and urine. So at the minute, his infection status is undetermined and is in follow-up. The case of sexual transmission, there was this couple who traveled to a Zika transmission country, and 5 days after they returned, he started with symptoms of rash, conjunctivitis, and lymphadenopathies. And while he was symptomatic, that first weeks of his symptoms, they had sexual intercourse with his female partner during 4 times. After 12 days, he started with symptoms and then having sexual intercourse, she started with exactly the same symptoms. And when we were able to study Zika, that was about a month and a half before they presented with the symptoms, we did several laboratory tests that we conclude that both of them had a Zika infection. Despite she also traveled to a Zika transmission country, she started with symptoms 18 days before they returned. That is too long for the incubation period, the maximum incubation period for Zika virus, which is 12 days. So after the biggest outbreak in Brazil, where more than 1 million people is think to have been affected with this virus, 2 complications have become evident. These are the congenital syndrome that was known before as the microcephaly in the newborns and Guillain-Barré syndrome. So Zika virus wasn't as innocent as we thought with the previous report in the previous outbreaks. So, is this association between Zika virus and microcephaly true? Well, the first alert was done by the Brazilian authorities in October last year, when they said they have an increase in newborns born with microcephaly, and after they installed active surveillance, they could realize that the incidence of microcephaly in newborn increased in a highest amount from 0.5 in between 10,000 newborn babies to 20. So it was really a big concern. So December of that year, WHO alerts that it's probably a relation between Zika infection during pregnancy and this outcome. And finally, at the beginning of February, the WHO declares Zika virus infection in the Americas as a public health emergency. So let's review the evidence for this association. This was the first report in a retrospective study in 35 newborns with microcephaly in Brazil, and they find that nearly 60% of them, the mothers, recall having symptoms during the first trimester. 70% of them had a really severe microcephaly, more than 3 standard deviations, and 100% of them had neurological abnormalities in neuroimaging. And many of them at the physical examination have a lot of abnormalities too. This is another report of a mother who had Zika infection in Brazil when she was in her 13th week of gestation. Is a European woman that went back to Europe, and there at the 29th week of gestation, the ultrasound of the baby showed cerebral calcifications and many abnormalities that was decided for the termination of the pregnancy at the 32 week of gestation. So the baby was examined, and the brain showed a lot of alteration in the development of the parenchyma, the cerebral parenchyma, and the ultrasound that was done while still in utero showed calcifications in the brain, and the virus by electronic microscopy and immunofluorescence showed the virus in the cerebral cells. No virus was found in any other parenchymas of the baby. Along with that, the Brazilian people have already reported that the Zika RNA was also found in amniotic fluid in 2 pregnant women with babies with microcephaly, and also later on Zika IgM also has been found in the CSF of neonates with microcephaly, and in the RNA of Zika also has been found in the brain of 2 Morty neonates in Brazil. And this is probably the first strongest evidence of the microcephaly and Zika infection. The first case control study, where we can see here that the cases, the infected women with Zika, 29% of them in the follow-up showed abnormalities in the babies with ultrasound, and none of the control group. And no matter what was the time the mother got the infection during the pregnancy, the possibility of having consequences of and complications were there. Even babies that the mother was infected at the 32nd week of gestation, this baby was still birthed. Same of this baby infected at the 27th week of gestation. And this is another strong evidence, the study retrospectively from French Polynesia, where we see here that 66% of the population, it seems to be, was affected, and the increase of the microcephaly, the incidence in mothers that were infected with Zika during pregnancies, it increased a lot, with 53% of relative risk. Also, ocular compromise has been detected after the studies, and we can see here this 34% of newborn with microcephaly had ocular compromise. 70% of them it is bilateral, and the common findings are this focal pigment mottling of the retina and chorioretinal atrophy. So, is Zika really the cause of this congenital syndrome? Well, in this just recent publication, where these authors compared with Shepard's criteria and Bradford Hill criteria, they said that in both methods, Zika infection during pregnancy fulfilled the majority of these criteria. So they conclude that there is enough evidence at the minute to say that Zika infection during pregnancy is a cause of microcephaly and other severe brain anomalies. The second complication, Guillain-Barré, is also appeared after the American outbreak, and several countries are reporting increases in the cases. In the Venezuelan countries, more than 70% of them had a Zika infection confirmed. Brazil is saying that the cases of Guillain-Barré increased in 19%. And the time when this complication appears is between 4 to 10 days after the onset of syndromes. And this is the strongest evidence to say that Guillain-Barré is related to Zika infection, and the rate of the risk is in one case of Guillain-Barré in 4,000 cases of Zika. Regarding to the sexual transmission, we can say that for far the transmission for Zika virus is by mosquitoes, but with this outbreak in the America, this new way of transmission has appeared, and up to today, more than 20 cases are being transmitted by sexual intercourse. All of them from male to male or male to female, and the time or the interval between the symptoms in the two partners is between 4 to 19 days. And infectious particles of the virus are being isolated from the semen of one man during 24 days after his onset of the symptoms. And the symptoms on the partners that acquire the virus from sexual transmission are exactly the same from those of the people acquire the virus from mosquitoes. To prevent this infection in places where the mosquito is present and the main form of transmission is this way, we have to use repellent containing DEET or picaridin during daytime. And to avoid the sexual transmission, the recommendations are the abstinence or use male condom during 2 months after a risk travel in asymptomatic male, or during 6 months after a risk travel in a male with symptomatic infection. And if the partner is pregnant, these precautions should be maintained during the whole pregnancy. So to finish my presentation, I would like to mention that Chile was considered, continental Chile was considered free of these Aedes from 1950s, where it was eradicated. But unfortunately, at the beginning of this month, in April, Aedes aegypti has been found in Arica city, which is in the northern part of our country, and is the surveillance is showing that the mosquito is widely spread in the city, so probably it's going to stay for a long time, with the consequent risk of the introduction of this arbovirus. So still many questions are answered, like what is the risk of the congenital infection after the maternal infection? What is the risk for a baby to become with the congenital syndrome after the fetal infection? What is the trimester that will impact more in the baby when the mother gets the infection? Or if the risk factors, what are the risk factors for these complications? Also, it's very important to know what is the impact of the asymptomatic infection in terms of they will transmit the virus, they will produce congenital syndrome or Guillain-Barré, or they will have sexual transmission if the male is asymptomatic. So still a lot of questions to be responded, and a lot of investigation is going on to try to respond these questions. So thank you very much for your attention. This is a picture of Santiago, the city where I live now in winter, with a nice picture of the Andes mountain, and I guarantee you that Aedes is free. Thank you.
Thank you very much, Dr. Perrette. Our next speaker is Dr. Ben Pinsky. Dr. Pinsky is Assistant Professor of Pathology as well as Assistant Professor of Medicine at the Stanford University School of Medicine. He is also the Medical Director of the Clinical Virology Laboratory at Stanford Health and co-directs the Global Health Diagnostics Fellowship Program. Dr. Pinsky will share with us his experience with Zika virus, diagnostic testing, and frontline management. Dr. Pinsky.
Thank you for the introduction, and thank you to Dr. Perrette for such an excellent presentation. The outline of my talk, I will primarily focus on the diagnostics part of Zika. I'll briefly talk about the virology and phylogeny, but that was already covered. I'll go through the markers of Zika virus infection and talk about nucleic acid amplification testing and serologic testing, and briefly touch on testing in pregnant women and neonates, and a last slide on the future directions of Zika testing. So we've already seen this. Zika is in the family Flaviviridae, the genus Flavivirus, and you can see it over here, relatively closely related to dengue. And as we've heard, it's an Aedes mosquito-borne infection. And here are just showing the American strains closely related to the Asian strains in French Polynesia and Yap Island, so forth. And then separate are the African lineages from earlier on. The virology, this is an envelope virus. It's 50 nanometers in diameter, and then recently the crystal structure was solved. Of course, it's a positive sense single-stranded RNA genome. The genome is about 10.8 kilobases in length. And here are the genes that are encoded, and you'll see that on some of the following slides. So the markers of infection, I'll go through this relatively quickly. We already heard that the incubation period is somewhere around 12 days or so. 14 days is what most folks quote for most of the arboviruses, although that data is relatively limited. And then the first marker that comes up is the viral RNA. So we'll talk about that as far as how to detect that in the acute phase. So here's the molecular testing algorithm that is recommended by the CDC. And molecular testing or testing for the viral RNA is recommended up to 7 days after symptom onset. And the recommendation is to perform real-time PCR for Zika virus as well as for dengue and chikungunya because, as has been discussed, these viruses present extremely similarly, and it's very difficult to tell them apart based on clinical characteristics alone. And the recommendation here for molecular testing up front is due to the extensive cross-reactivity in the serologic assays. And I'll get to that later on in the talk. I also want to mention that briefly for dengue, there are examples of Zika virus NS1 protein, NS1 antigen that is detected by dengue NS1 assays. So there can be also false positives with the NS1 assay. So the best bet here is to perform testing for the viral RNA. So most of the nucleic acid amplification testing is performed on serum, and in the literature, the assay that's most frequently performed is the CDC Zika real-time RT-PCR. These are two assays based on sequence from the Yap Islands outbreak in 2007 and published by Lanciotti and colleagues in 2008. The targets are the membrane gene and envelope gene in two separate reactions, and it requires detection in both reactions with CT values less than 38.5 to call a positive. This table just shows the data from the Yap Island outbreak, where 17 of the 157 patients that met clinical criteria had positive PCR. Importantly, 88% of the positives were collected within the first 3 days of illness, suggesting that patients are not viremic for very long with Zika. And this was similarly observed during the 2013-2014 French Polynesia outbreak, where there was also a short duration of viremia. In that study, there was mean day of illness was 3.3 days with a standard deviation of 1.8. So what about the level of viremia in these patients? So in the Yap Island study from the CDC using their PCR, the mean Zika virus level was 4.4 log 10 copies per ml with a standard deviation of about 1 log. So this is relatively low for these arboviral infections. We have done a study in Nicaragua during this year where we used a different assay, a Zika Chick Dengue multiplex that I'll talk about a little bit later. And you can see the data here on the y-axis of viremia in log 10 copies per ml of serum, and then which virus on the x-axis. And our mean Zika level was very similar to what was seen in the Yap Islands outbreak, 4.9 log 10 copies per ml with a standard deviation of 1. You can see some other interesting things here in addition is that the distribution of positive results for both dengue and chikungunya are sort of bimodal, where there's some very high viral loads and then some very low ones. And then more importantly, you can see here evidence that indeed the Zika virus level is statistically significantly lower than the mean level for dengue and chikungunya, which I think is fairly obvious. So a point here is that it may be useful to have relatively analytically sensitive Zika virus tests in order to detect all the cases of Zika, considering the mean viral load is relatively low. And in addition, this may allow detection of virus later on in the course of illness. So what about some other alternative specimen types to help identify Zika RNA in patients that may be infected? So in the French Polynesia study, there's a really nice work on saliva, and they use the CDC's original Zika assay. And the data is shown here comparing saliva versus serum, and many of the patients were both serum positive and saliva positive, but you can see that significantly more of the patients were positive in saliva than in serum, and this was statistically significant. So saliva may be a nice alternative specimen type in order to detect more cases of Zika infection. However, the mean day of illness was not statistically significantly different from the mean day of illness in serum, so 3.5 days. And if you remember, the mean day of illness in serum was 3.3 from the same study. And you can see here, this is just, again, showing the data on the right with, this is the number of cases on the y-axis and the day of illness on the x. And the saliva cases, blood cases, and then saliva and blood together, which was the most frequent. So another alternative specimen type is urine. The best study for this was performed in New Caledonia, another Pacific island, in 2014. And they showed that Zika RNA may be detectable in urine for 7 or more days after it is no longer detectable in serum. And you can see that in these 6 patients where the top line is the urine, and the bottom line in all these is the serum. It's a little bit hard to see, but on the y-axis is the CT values, giving an idea of the quantity of viral RNA in the specimen, and then on the x-axis is the day of onset. So this case series suggests that Zika RNA may persist in the urine, and that this may be another good alternative specimen type. However, in one of the pregnancy studies from Brazil in 2015, Zika RNA was actually more frequently detected in the serum compared to the urine. So perhaps, and that's shown here, 13.6% were urine positive, serum negative, but 29.5% were urine negative, serum positive. So this suggests that perhaps getting both a serum and a urine would increase the detection of Zika in these patients, and perhaps getting serum, urine, and saliva would increase even more. So there's other alternative specimen types that have been demonstrated in the literature, including amniotic fluid, which may be important for determining infection of the fetus. In CSF, it has been shown in actually only one case that we found where a patient had Guillain-Barré syndrome and both chikungunya and Zika virus in their CSF. The large study in French Polynesia that looked at Guillain-Barré and its association with Zika did not find Zika virus RNA in the CSF in their patients. Zika has been detected in semen and as well as in fetal tissues. So what are the assays that have been demonstrated in the literature? So these are the published assays to my knowledge, and you can look these up with these references, and we've also written a review about this in the Journal of Clinical Microbiology. And I'll talk about some of them, in particular the Trioplex assay, which has been from the CDC, which has obtained emergency use authorization. And hot off the presses this morning, the Quest Focus Zika virus RNA qualitative PCR also received emergency use authorization. I won't cover that. I didn't have time to make those particular slides. A number of other laboratories and diagnostics manufacturers have submitted data to the FDA for approval, and I suspect we'll have many more options for Zika virus testing in the coming months. So how does this CDC Trioplex assay perform, and what is it? So this is a multiplex TACMAN assay. The indication for use is the detection and differentiation of RNA from dengue, chikungunya, and Zika viruses in serum, CSF, and for the detection of Zika virus RNA in urine and amniotic fluid. Again, the result is interpreted as positive if the reaction generates a fluorescent growth curve that crosses the threshold, in this case 38 cycles. And the lower limits of detection are actually relatively high, so 4 to 5.5 genome copies equivalent for ml of serum for Zika, dengue, and chikungunya. I picked dengue for that. This is the most sensitive of the dengue. The other serotypes are less sensitive. And I just wanted to point this out. You can, for Zika in particular, the Zika virus mean value of mean viremia was about 4.5 log 10 copies per ml. So the lower limit of detection is awfully close to the mean value in patients. This assay showed excellent in silico inclusivity and exclusivity, and they did some cross-reactivity studies, and there was no cross-reactivity with other flavies, including West Nile, yellow fever, and St. Louis encephalitis virus. And they did test some archive samples, including 20 that were positive for Zika virus, and with a total number of 130. And they agreed with single target CDC assays. Positive percent agreement was close to 98%, and negative percent agreement was 98.2% or greater. So some disclaimers about this assay. I mentioned the lower limit of detection, potential issue with lower limit of detection, and co-infections were not evaluated. And I'll show you some data that these may be quite common. It was not extensively tested with clinical specimens, and this is really a weakness of many of the assays. Just evaluations of specimens in the countries that are having ongoing transmission have not yet been performed. These archive samples were not randomly selected. Approval was obtained with 2 urine and 2 amniotic fluid samples. And the assays that they compared it to were actually, for Zika anyway, was not the assay that has been highly published. So the Zika assay and the chikungunya assay are of unknown performance characteristics. And in addition, the dengue assay has been shown numerous times in the literature to be less sensitive than other molecular dengue assays. Importantly, for sort of use of laboratories throughout the world, the genomic targets were not disclosed. And of course, testing is limited to qualified laboratories designated by the CDC, so CDC laboratories and state and local public health labs. So my residents got me this T-shirt and says I was testing for Zika before Zika was cool. So I'm going to tell you about an alternative. And this T-shirt was made actually before the crystal structure of Zika. So we have actually dengue on there. They look pretty similar. So I'll tell you about an alternative Zika virus RT-PCR that we designed. It would target the NS4B gene. It's designed using all complete or nearly complete Zika genome sequences available in GenBank. At the time we accessed it was 28th of March 2014. The first assays were run on April 4th, 2014. So the T-shirt is actually quite accurate. And then we've confirmed, as more sequences have come out, that these primers and probes have 100% match to strains from the Americas. And we combine this assay in multiplex with previously described chikungunya and dengue virus assays, and we term this the ZCD assay. It also uses TACMAN chemistry, and performance has been validated on multiple real-time PCR instruments, including the ABI 7500, the rotor gene and Biorad instruments, and it's been validated with numerous extraction methods. And so in a single reaction, similar to the trioplex, it detects and distinguishes between these co-circulating arboviruses. So we did an analytical evaluation. So the linear range was broad. The lower limit of detection was very low, at least tenfold lower than what's described for the trioplex assay. And we examined exclusivity by testing genomic RNA from a large number of related viruses, as you can see here, and no amplification was observed. We did a clinical evaluation in Nicaragua. This test has been run there and used to screen national surveillance samples as well as a variety of research studies since last fall. And the first samples were identified in early 2016. And we looked at then 133 consecutive samples once Zika was identified in the country. And we compared the ZCD assay with the original CDC Zika RT-PCR that targets the E gene. And you can see the performance here that Zika was detected in significantly more Nicaraguan samples using our Zika assay than the comparator. And interestingly, about 30% of the positives showed evidence of a mixed infection. We had 10 chick Zika, 3 dengue Zika, and even 4 that had all 4 viruses circulating in the same patient. So I'll switch gears here and start talking about the serologic tests. So if we go back to the markers of infection, the IgM antibodies are thought to become apparent at around 4 days after the onset of symptoms. So IgM assays have been used quite extensively in the diagnosis of Zika as well as dengue, and that's part of where the problem comes in. So again, here's the CDC's serological testing algorithm recommending testing for dengue, Zika, and chikungunya IgM. And if positive, it's presumptive infection. And then, but to distinguish between, really between Zika and other flavivirus infections, one at this point needs to perform plaque reduction neutralization testing. So for Zika, Zika IgM is detected, as I said, at about 4 days after the onset of illness and may persist for 2 to 12 weeks or longer. Previous infection or vaccination with other flaviviruses like dengue, Japanese encephalitis virus, or yellow fever may result in false positive IgM results. And this has been demonstrated in numerous reports, case reports of returning travelers, that they often are misdiagnosed with dengue because of false positive IgM assays. To my knowledge, there's one emergency use authorization for IgM, Zika IgM, which is the CDC's IgM capture ELISA. And though other manufacturers are certainly submitting their data to the FDA for emergency use authorization. And I believe there is a CE marked assay from Euroimmune that may be available to perform in the United States. So as I mentioned, to distinguish between these flavivirus infections and positive IgM results, one needs to perform plaque reduction neutralization testing. So that's shown here for dengue, and you're looking for the reduction in the numbers of plaques, suggesting that the antibodies are neutralizing for cell infections. So the 90% reduction, PRNT90, is used to distinguish Zika from dengue. And it's a little bit hard to find what the criteria for Zika, what the criteria that's being used for Zika virus positive. In some publications, it's the titer that's greater than 4-fold compared to other flavivirus that are tested. Or if one is fortunate to have both an acute and convalescent sera, one can look for a 4-fold increase in the titer of Zika virus antibodies. So this is probably really hard to read, but this is some of the data of the CDC MAC ELISA from the Yap Island outbreak in the publication from 2008. And you can see here in patients that are thought to have never before been exposed to a flavivirus, Zika IgM does reasonably well. So I should say the cutoff here is 3 units. And you can see that, sorry, the dengue signal is actually, most of these patients are low, and actually this patient may actually have dengue. And then, however, one gets into trouble with the secondary flavivirus infections. So patients that have previously had dengue or another flavi. Here's again the Zika signals. But then if you look at dengue, most of these are actually positive for dengue IgM. And then there's actually some very high signals in like JE. I guess I didn't circle those. In JE, as well as some for yellow fever, and even some positives for Murray Valley. When PRNT was performed, you can see that this was very helpful in the primary flavivirus. So those had very high titers compared to the other, Zika virus had very high titers compared to the other flavies. However, in secondary flavivirus infection, there were high titers in Zika as well as in dengue, and this could get very complicated to interpret. So some data from the package insert from the IgM ELISA from CDC. You can see here the positive % agreement is good between the IgM assay and the PRNT here, 45 out of 46. However, the negative % agreement or the specificity looks pretty poor. For PRNT results that are not Zika, which is in this calculation is the dengue and negatives. These are sort of the flavivirus are considered indeterminate. It's 45 out of 99 agree. So that's 45%, so not so great. So some disclaimers for this assay and the PRNT process. Very low specificity, as I've shown, and PRNT is unable to resolve close to 20% of IgM ELISA positive specimens. And again, this testing is relatively limited, and PRNT is quite laborious, so the results take quite some time to be returned to clinicians that might need to use it. So this is from the CDC's website. Given the current volume of samples, test results will not be available for at least 3 weeks after specimen receipt. Reporting times for test results may be longer during summer months or when arbovirus activity increases. Of course, I should mention that many of the state laboratories are also performing testing, so the time that you may receive your test results may be much shorter than this. The package insert for the MAC ELISA also tells where one can obtain both chikungunya and and dengue assays from commercial reference labs or from diagnostics manufacturers, and it looks like I forgot to put the dengue ELISA diagnostic manufacturers on there. So I apologize to InBios, who I believe has an FDA-cleared assay. So just in the last couple minutes that I have, I'm going to talk about testing in pregnant women and in neonates. So here on the left is the pregnancy algorithm. So it's thought that pregnant women will likely not seek medical care, may not seek medical care when they're acutely ill. So the recommendation is to perform antibody testing. So IgM for Zika. If it's positive, perform dengue because of the issues with cross-reactivity. And then if dengue is negative, it's a probable Zika virus. What to do next is not necessarily recommended. There's no recommendations provided, but one may consider performing amniotic fluid testing if that may be indicated. If it's dengue is positive, it's an unspecified flavi, and PRNT testing may be helpful in discriminating between Zika and other flaviviruses. For neonatal testing, one can test many of the specimen types that we've already talked about. So serum testing for both RNA and antibodies, CSF testing for RNA and antibodies. One can test the placenta and umbilical cord by histopathologic evaluation, immunohistochemical staining on fixed tissues, so this is not widely available, and then RT-PCR on fixed and frozen tissue, and then they recommend testing maternal serum if it hasn't already been done. So what's next for these diagnostics? So I think hopefully there will be widespread availability of well-characterized nucleic acid amplification tests and antibody tests for clinical diagnostic laboratories to improve turnaround time and make these assays potentially more clinically relevant. And then there really needs to be work on improvement of Zika virus IgM antibody test specificity. There's folks that are working on identification of Zika virus specific epitopes, and then the reverse of deleting common epitopes. So hopefully that will improve Zika virus IgM testing, although perhaps this is our immunology and biology and maybe difficult to overcome. I think that it's important to develop alternatives to plaque reduction neutralization testing. And folks at the University of Washington, Rusal Sedlak and Keith Jerome are working on a Zika virus Western blot, so that may be helpful to distinguish Zika from dengue and other flaviviruses. Zika virus NS1 assays. So NS1 assays are commonly used for dengue, so this may be very helpful to roll out Zika virus testing to places that are not able to perform molecular diagnostics. And then moving all of these assays to near care and point of care testing with sample to answer systems, and really getting this out so that these infections can be accurately diagnosed. So with that, I'd like to thank AMP, PASCV. Thanks to Jesse Wagner, who has done a lot of the work that we've shown, that our lab has done, as well as Malay Sahu, who has been an amazing tech in the lab and postdoc. So with that, I think we'll start taking questions, and thank you all the folks online for listening for the last 55 minutes.
Thank you very much, Dr. Pinsky. We do have a few questions. I'd like to remind all of our listeners that if they have any questions themselves that they would like to submit, they can do so via the control panel. The first question we have is for Dr. Perrett, and this question is regarding Zika testing, and is it performed at the local hospital laboratories, or is it performed at a central laboratory, and then how long does it take to get those results?
You might be on mute, Dr. Perrett.
Sorry. Can you hear me now?
Yes, we can.
Yes. So we have both private and public laboratory. The public one is a reference national laboratory, but according to our guidelines, the national reference laboratory is only testing suspected cases on pregnant women or persons with Guillain-Barré syndrome related with Zika infection, or suspected cases coming from Easter Island or the Arica city, which I mentioned now. We have the Aedes circulating to discover if the virus has been introduced to our country. But at the private laboratory, which is one at the university lab, we can perform to anyone that wants to have or to be tested, and we have a PCR and serology, IgM, and IgG.
Thank you very much. This question is probably more for Dr. Pinsky. Is the FDA or Red Cross looking at testing blood products, and if so, via what method?
Yeah, my understanding is that blood is being screened in Puerto Rico by a method developed by Roche. I don't know the details of that, but blood screening is going on, and there's a lot of interest in protecting the blood supply from Zika, as well as from dengue and chikungunya.
All right. This question is for either panelist, and that is there any data regarding the risk of microcephaly or Guillain-Barré, and that risk being stratified by having a primary or secondary flavivirus infection?
The only thing I know is that that report from the French Polynesia about Guillain-Barré, they used a control group to find out if the previous infection with dengue was considered a risk factor to have this complication after Zika infection, and they couldn't find that was a relation between previous infection with dengue to more risk of Guillain-Barré in people with a Zika infection. Regarding to pregnancy and complications with microcephaly, as far as I know, there's no any investigation or results that could tell us if there is a more risk if you have a previous flavivirus infection. But it still is one of the questions that need answers.
All right, thank you. There's one more question, and this is regarding the ZDC assay that Dr. Pinsky described. And the question is, when you're using the ZDC assay, does it change the mean or median duration of positivity?
Yeah, that's an excellent question. We're doing those studies now to determine how far out we can, how far after the onset of symptoms we will be able to detect viral RNA in serum. The longest we've detected is 12 days, and there's reports of detection over a number of weeks in some patients. That's not work that we've done, but that work is ongoing. So I guess stay tuned.
All right. Well, thank you both very much once again. That concludes our question and answer session. We thank all of the participants for tuning in and hope to hear from you guys at future AMP and PASCV events. Thank you very much.